take us through her presentation. Dr. Success, you have 15 minutes. Try as much as possible to help us present this in 15 minutes. Thank you very much. So, Dr. Success, you have the floor now, so you can.
Okay. Thank you so much, Dr. Atta. Good morning, my teachers, senior colleagues, and colleagues. So we'll be discussing question 3B of WACP April 2023. I'm Dr. Bamba Success. These are the questions. 1, what is diabetic ketoacidosis? 2, how do you make the diagnosis? 3, what are the current ways of managing it? 4, define diabetic foot syndrome. And 5, outline the management of diabetic foot syndrome. The first question, what is diabetic ketoacidosis? I will be using DKA for short. DKA is an acute, potentially life-threatening complication of diabetes, characterized by hyperglycemia of blood glucose of more than 14 millimoles per liter, ketonemia of more than 5 milliequivalent per liter, and high anion gap, metabolic acidosis of bicarbonate less than 18 millimole per liter. It occurs when there's deficiency in insulin, causing inhibiting the glucose from entering the cell, thus making ketone an alternative source of fuel. This predominantly occurs in type 1 diabetes. How do you make a diagnosis? Diagnosis is made from history, examination, and investigation. The patient may have symptoms of hyperglycemia, which includes polyuria, polydipsia, nocturia, weight loss, and muscle cramps. Other clinical features that can be seen include signs of recurrent infections like cellulitis, urinary tract infection. Others include tachycardia, small breathing, which is a mark of acidosis, acetone breath, and nausea and vomiting. These patients may experience including abdominal tenderness. Now, the nausea and vomiting is not about the effect of high ketone bodies on the brainstem. Okay, so these are called chemoreceptors, and they stimulate the emetic center in the medulla, and this triggers a reflex that causes nauseous sensation and vomiting. This patient may also have impaired consciousness. Now, to make the diagnosis, the following investigations should be requested for: random blood glucose urinalysis, share blood gas monitoring, glycated hemoglobin A1C, lipid profile, and others as listed. Now, what are the current ways of managing it? The principles of management include replacement of fluid and electrolyte losses, correction of hypoglycemia and metabolic acidosis, detection and, of course, prevention of precipitating factors. Now, it's important that we also convert this patient to a maintenance diabetic regimen. This will help to prevent reoccurrence. It's important we also that the comorbidities are treated and complications are identified and prevented. Now, using the FICA acronym, the fluid usually, patients with DK, they are dehydrated and they have lost about 6 liters of fluid, and so they are given isotonic fluid saline at the rate of 15 to 20 ml per kg per weight, 1 to 2 liters during the first 1 hour, and another 1 liter during the second hour. Another liter is given following the second hour, and 1 liter is given 4 hourly, depending on the degree of dehydration, with a target of an estimated water and sodium deficit over to replace half of the estimated water and sodium deficit over a period of 12 to 24 hours. Now, insulin is given, and insulin is given in continuous infusion after the initial intravenous bolus of regular insulin is given at 0.1 unit per kg. According to the Joint British Diabetes Society guideline, the recommendation is that intravenous insulin infusion be given at a weight-based rate until the ketosis have subsided. If the random blood glucose is less than 14 milliliters of mercury, 10% glucose should be added to allow for continuation of the fixed rate insulin infusion. Now, the optimal rate of reduction is between 3 to 4 millimole per hour. Potassium can also be given if this patient has hypokalemia, although we know that in DKA, there's mild to moderate hyperglycemia because these patients have acidosis and insulinopenia. However, when this insulin is being when insulin therapy is instituted and the acidosis is corrected, these patients, they are, this actually decreases, the serum concentration of patients with DK, and hence it's important that potassium is given at a dose of 20 millimole in each liter to maintain in a normal range of 4 to 5 millimole per liter. Now, this is the measurement of potassium repletion in DKA. If it is more than 5.2, we do not give. It is less than 3.3, insulin is withheld, and sodium is given at a rate of 20 to 30 until it is more than 3.3. And the potassium, if the level is 3.3 to 5.2, it is given 20 to 30 milliliters in each liter of intravenous fluid to maintain it at the level of 4 to 5 millimole per liter. Now, even bicarbonate too is routinely not given because when insulin therapy is instituted, it inhibits lipolysis and also corrects the ketoacidosis. However, when ketoacidosis is severe and there's cardiac compromise, intravenous bicarbonate is instituted. And this therapy has some side effects such as hypokalemia and cerebral edema. If cerebral edema occurs, it's important that this patient should be monitored and also, of course, treated with interventions such as hyperventilation, intubation, and also intracranial pressure monitoring, which will help to improve outcomes. What is diabetic? Define diabetic foot syndrome. DFS is defined by World Health Organization as ostration of the feet distally from the ankle, including the ankle, with associated neuropathy and different grades of ischemia and infection. The pathologic events that cause DFU are multifactorial. These are the risk factors of DFU. Now, what's the principle of management of DFS? According to the American Diabetes Association consensus statement, this involves a multidisciplinary approach involving the endocrinologist, orthopedic surgeons, the dietitian, the diabetic nurse, and also offloading the wound, good glycemic control, limited amputation. This is the small mnemonic that could help us to actually actualize, to help us remember the principles of management in DFU. G for good glycemic control, offloading, debris, more wound dressing. Of course, patient information education is important because this will actually help to reduce the risk of ostration and limb amputation. And of course, these patients will be told to daily inspect their feet and also wear appropriate footwear and avoid walking barefooted. How to make a diagnosis of diabetic foot syndrome? From the history, okay, so is there a history of trauma or puncture wound? Sometimes it may be spontaneous, and there are signs of local or systemic signs of infection. Does this patient have features of peripheral neuropathy, such as paresthesia, hyperesthesia, dysesthesia? The patient has features of peripheral artery disease like ischemic pain at rest or intermittent claudication. Someone we examine the ulcer, the feet, and also assess the possibility of vascular insufficiency and peripheral neuropathy. Now, for the pathophysiology of DFU, I know it has been extensively discussed 3 days ago, but I want to summarize that the following pathways are implicated: the paleo pathway, hexosamine pathway, the advanced glycation end product pathway, and also the diacylglycerol pathway. All these will cause angiopathy, neuropathy, ischemia, structural damage, and of course, leading to ulceration. Now, these are the differentials for DFU. They include basal cell carcinoma, it could be from bites, cutaneous B-cell lymphoma, pyoderma gangrenosum, Kaposi sarcoma, and of course, pressure injuries. The investigations that can be done, patients that have DFE include, apart from those that have been previously stated, the wound MCS, the X-ray of the foot, okay, to show if there are foreign bodies, tissue swelling, osteomyelitis, and also it's important for us to measure the ankle breaker index. Other investigations include pulse volume recording, pulse, ultrasonography, even CT and MRI, and of course, bone scans, angiography, bone biopsy, and probe to bone test. Now, according to the International Working Group of Diabetes in 2023 guidelines, research find the system and screening for patients with DFU. It was categorized into very low, moderate, high. Okay, so for patients with very low, they should screen once a year, while for those with very high risk, should screen once in 3 months. And so even that for the wound clinical category, graded 0 to 3, for patients with grade 0, they have ischemic rest pain without ulcer, frank ulcer or gangrene, while patients in grade 3, they have extensive ulcer gangrene or gangrene has more than 10 centimeters square, involving the forefoot and hind limb. And this, at this stage, it can only be salvageable by reconstruction. Now, even the classification on the foot infection, we graded 0 to 3. For DKA, the participants of DKA have these small mnemonics disease eyes, which include insulin deficiency in patients that are newly undiagnosed, and they present first with DKA. Of course, these patients are not on insulin therapy, or patients that are even diabetics and not compliant with medication or underdose. Other presents include inflammation, infections, intoxication, infections such as acute myocardial infarction, stroke, and iatrogenic. So for the pathophysiology of DKA, I want to summarize it in this way. Now, we know that insulin helps glucose to move into the cell where glycolysis occurs, and of course, it's converted to pyruvate and enters the Krebs cycle as acetyl-CoA, where ATP is finally produced. Now, apart from that, so insulin also prevents beta oxidation. So this prevents acid from moving, fatty acids from moving into the cell. However, when patients now have DKA, there's relative or there's insulin deficiency, causing this triglycerides to be broken down to free acid via lipolysis. And of course, the free fatty acids are broken down to acetyl-CoA via beta oxidation. The acetyl-CoA saturates the Krebs cycle, and now is synthesized to ketone bodies. The process by which acetylcholine is converted to ketone bodies is known as ketogenesis. These ketone bodies include acetoacetate, beta hydroxybutyrate, and acetone. They actually enter the acetoacetate and beta hydroxybutyrate enter into the into the bloodstream, and they release protons, making the blood acidic. Okay, so that's how ketoacidosis occurs in patients with DKA. Of course, we know that because of the elevated levels of the pro-inflammatory cytokines, it now makes DKA a pro-metabolic state. Sorry, it makes it a pro-inflammatory and a pro-coagulant state. Now, this is just a summary of what I've talked about. Okay, from when there's a reduced insulin deficiency, there's increased electrolysis, and of course, increased lipolysis. And at the end of the day, this causes increased lactic acidosis, reduced renal function, and of course, potassium and hypokalemia. Now, these are the causes of mortality and morbidity in patients with TKA, and they include shock, hypokalemia during treatment, cerebral edema during treatment, also acute respiratory distress syndrome, acute renal syndrome, then participating illness too, like stroke, sepsis, pancreatitis, and pneumonia. This is the flu therapy in DKA that I've already talked about, and the insulin therapy I've already discussed. It's important for us to anticoagulate these patients, as a way of DVT prophylaxis. And example of agents we give them include subcutaneous enoxaparin. Now, it's important that these patients too, we transit them to subcut insulin after the DKA has resolved. Okay, so after that initial intravenous therapy, these patients, it's important we give them subcut basal insulin. An example of that is glycine or detamine. Now, it's also important for us to know that analogs result in similar blood glucose control, but but they have actually they give less hypoglycemia compared to human insulin analogs. So these are the precipitating factors in DKA. And it's important that, and this checklist is also important for these patients. Okay, so it's important to tell about the diet information, their treatment goals, and of course, medic alert bracelets, so that in case they have attacks, they can subsequently be, help can be given appropriately. Now, this table showing the difference between DKA and HHS. Now, in DKA, there's absolute or near absolute insulin deficiency, and so this results in severe hyperglycemia and ketosis, ketoacidosis. While in HHS, there's relative insulin deficiency causing hyperglycemia, but they do not have profound ketoacidosis. DKA occurs acutely over 1 to 2 days, while HHS occurs subacutely over days to weeks. Then for DKA, it's mostly seen in patients with type 1 diabetes, while HHS is seen mainly in patients with type 2 diabetes and also has a higher mortality. Now, these are actually the ranges and the parameters differentiating DKA and HHS. Of course, because of the ketoacidosis, we expect that the pH will be less in DKA compared to HHS. Okay, then including ketone bodies such as hydroxybutyrate, we expect that it should be seen in DKA, okay, and not in HHS. Even the serum ketones, urine ketones will be higher in more, or will be profoundly seen in DKA when compared to HHS. Okay, so that is most of what I have for the slides. Then this last slide shows, categorizes DKA into mild, moderate, and severe. Of course, you know that when there is severe DKA, the patient is stuporous or comatose. Thank you for listening.
Yeah, thank you, Dr. Success, for a wonderful presentation. So the class is open for comments, contributions, questions. We can raise our hand electronically, or you type in the chat box. Please, let's contribute and let's save time before the next person comes. Any contributions, any clarifications? Most of the comments in the chat box they're applauding your presentation. But Dr. Ifoma is saying about the duration of HHS versus DK, they are both acute.
Yeah, they are both acute, but DK is more acute than HHS.
Okay. Any other contributions? Okay. Dr. Chinwe say, please, are there precautionary measures to take before potassium administration?
Yeah, so I've said that. Okay.
Yeah. No, continue. Just answer. I'll take it one by one.
Okay. So I've said that for us to give potassium, we should make sure that the patient's renal status is intact. Then we should also make sure that the potassium is not more than 5.2. So remember that I said initially, DK can also cause hyperkalemia. Okay, so that's why we need to measure. Okay, so when it is more than 5.2, you don't want to give. And of course, when the patient has impaired renal status, you want to be careful with potassium administration. Thank you.
Hello,
Hello, am I being heard?
Dr.
we
Is that Dr.
lost you at
Stockton?
some point.
Okay.
Yeah, we lost you at some point.
Oh,
not hearing
sorry.
what
I'm
you
so
said.
sorry. Okay. So I was saying that before potassium, should be given, these patients should, first of all, we should make sure that they don't have impaired renal status. Okay. Secondly, we should also make sure that the potassium is not more than 5.2, okay, millimole per liter. So as much as possible, we want to be careful when this patient has, impaired renal status. Yes, before we give potassium. Thank you.
Okay, Dr. Shamsuddin, you can go ahead with your contribution.
Thank you very much for the presentation. I think
Hello.
it's also, thank you for the presentation. I think it's also it
Hello,
will give you
Dr. Dr. Shamsuddin, your line is breaking. Can you hear us?
I can hear you. Thank you very much for the presentation.
We cannot hear you. Okay, Dr. Fei, while we are waiting for Shamsuddin, maybe later.
Good morning to our teachers and good morning, everyone. Thank you, Dr. Success, for the beautiful presentation. Well, as regards how will you make the diagnosis, I wouldn't know whether they want us to go specific, maybe for those who went for the exam, or they want us to just list out investigations. Because we know for DK, there's a triad of ketosis. You mentioned them, but I wouldn't know whether they want us to specify, blood glucose more than 250 milligrams per DL, acidosis pH less than 7.3, or maybe just to list out those investigations. Whether they want us to specify those trials. I mean, listing order.
Okay, while those that went for the exam will comment, I want to say that the questions are not actually the same. The first question was, what is diabetic ketoacidosis? And the second is, how do you make the diagnosis? So the first is what is, so you say the triad. Then for the diagnosis, we know that making diagnosis is from history, examination, and of course investigation. So they are not, they are different stems. Thank you.
Okay, Dr. Fei, are you done with your contribution or what to?
Thank you, sir.
Okay. If you are not speaking, can you mute your mic? Okay, so let me go to the chat.
Please. Hello.
Hello.
Please, can I say something? Please, can I have it?
Okay,
please, can you hear me? Sorry.
Dr. Anthony. Okay.
Please, it was a little clarification, please. First, I want to thank her for doing a very good job. Initially, I was a little confused when she started because I didn't really start at the very beginning. But at the time, she talked about DKA. At the time, she talked about diabetic foot syndrome, and then much later she started talking about DKA. But my own question is,
sorry. I
based
think
on
I won't have logged out. That's how the question is. The first is, what is DKA? The second is, how do you make the diagnosis of DKA? The third is, what are the current ways of managing DKA? Then the fourth question is, define diabetic foot syndrome. And the fifth is, outline the management of diabetic foot syndrome. That's the stem of the question.
Okay. So in principle, you were talking about diabetic ketoacidosis. I guess that's what you were discussing.
No, I talked of both, the principles of management of both. Okay, so the principles of management for DKA and the principles of management for DFU. Of course, you know that they are the same, but they are slightly different. Okay, because in management of DFU, we'll talk of offloading the foot, revascularization or reconstruction surgery or limb amputation where necessary. Of course, the patient with DKA does not have DFU. That may not be what we want to target as managing the patient. I don't know if you understand. So the principles are, yes, they are both complications of diabetes. Okay, so things like having appropriate, glycemic control, good glycemic control, that is excellent for both of them. But in, specific management, like talking of wound dressing and those other stuff, we won't be talking of that in DKA. Yes.
Okay. But I also wanted to remind, what you said about correction of potassium. I think there is either the American guidelines, which is very clear cut. I don't know, maybe I think maybe you were discussing it in the setting of our own environment, maybe where you need to monitor. But I think, I think the American guidelines, if I'm really correct anyway, and I need to check up, so maybe specific or so that you should be given based on what the potassium levels is. Either you're giving 40. I think if the American guideline says something about giving 40, if I'm correct. Did you mention it?
Okay, so let's also delineate between potassium correction in DK and potassium correction in HHS. Okay, now in patients that have DKA, don't forget that their mechanism of hypokalemia is not also the same as those that have HHS. Now, what causes acidosis or what causes hypokalemia in patients with DKA? You know that initially patients with DKA, they even have hypercalcemia because of the acidosis. Okay, now because of the accumulation of ketone bodies in the intracellular fluid, they now enter into the cell, into the intracellular space in such a way that the proton, which is the hydrogen ion, as it enters into the cell, potassium comes out of the cell. Okay, and this happens in several cells, causing hyperkalemia. So initially, what is actually seen is hyperkalemia due to this due to this. But with time, as potassium keeps coming out of the cell, there's this total depletion of potassium. And even when you give the insulin therapy, and you even you correct, when you give the insulin therapy, that can also decrease your potassium serum potassium concentration. So you can see that initially the patient, it starts with hyperkalemia before in event of time it becomes hypo. And that is why we monitor. And we say, okay, if this patient's level is more than 5.2, we do not give them potassium. But when we check the levels of the potassium, and it's between 3.3 to 5.2, you want to give 20 to 30 milli equivalent of potassium in each fluid to maintain the potassium to 4 to 5 milli equivalent per liter. And of course, if the potassium is less than 3.3, you don't want to give insulin because, like I said, insulin causes hypokalemia. So you want to withhold insulin, then correct the potassium, okay, by giving the patient the 20 to 30 milli equivalent per hour, okay, until the potassium is corrected to more than 3.3 before you now institute your insulin, continue your insulin therapy. So they are not the same guidelines for DK and HHS. Thank you.
Dr. Atta?
Yes, ma'am.
Yes, what's is there any area of contention? We need to be
Yeah,
running
so
up this session. It's already
yes.
7:40.
Well, for this particular one is the withholding. Well, the sliding scale for potassium um, correction or potassium treatment in patients you are treating for decay. And then why will you want to withhold potassium when somebody is already having, like ketonemia and ketoacidosis, and then you pursue treatment of potassium? Basically, that's the question she just tried to explain. I know there are a lot of questions in the chat box too that we have not.
There are a
Loads
lot
of
of
questions
questions.
in the chat
And
box.
what I want to come in is we should not pursue shadows. I listened to her presentation. To me, it was even too detailed. Exam, and I love the way she did it. It will give so much details here. So once you go for exam, if it is 5 out of 10, you remember, it's fine. This question was a bonus question, safe in that exam. Most of the people that went for that exam, they were saying that if they finished and they were registering with the examiners. Because most of the things they were asking were not details, were list. Wasn't too much discussion. It wasn't too much discussion. So most will say, okay, so they ask them that because there was time. Okay, now you've mentioned DKA, what is osmolality, what is this? Because there was time. Because it was a list station. So what we teach people in this class is if they give you a question, focus on the question. Don't start pursuing things that will put you in trouble. From then now, they'll ask you something that maybe a new update that was released 24 hours ago that you are not aware of. Or you put yourself in trouble. If they ask you to list. If they ask you to discuss. But I love the discussion, it's nice, but I want also focus on the question so that most people will listen to this now, record those who listen to it, and if something similar comes up, you just see them go in the direction of the confusion. So while we love participation, please let's just make it to be within the question asked. So thank you once again. So Dr. Atta, please read the comments and the questions in the chat box. In the recording, sometimes we don't see what is in the chat box. So that a second presenter can quickly present. It's already 7:31.
Okay. All right. I think Dr. Momodu was asking question in line with the last question that was asked. Dr. Lighton, clarification on if potassium is less than 3.3 hold insulin. What if blood glucose is still very high? Do you want to still withhold insulin because the potassium is less than 3.3? That's the question
You correct and then give insulin. I think I've adjusted. Yes, you correct the potassium, then give insulin. Because insulin, like I said, causes hypokalemia. So you want to make sure that, the potassium is within normal range before you are giving, at least more than 3.3 before insulin is given. Yes. Or is continued.
Dr. Afolabi is saying, what is the type and dose of insulin that should be given to this patient after DKA has resolved?
Okay, so it was
yes. Okay.
Yes, so it was part of what I presented. I said when the DKA has resolved, these patients should actually, be given, subcutaneous insulin. Okay, it should be transited to subcutaneous insulin after resolution of the DKA. And I said what is usually preferred is, the analogs. Okay, because they actually control glucose better and they have less hypoglycemic effect. So compared to the human insulin analogs. Thank you.
Then they say which is the true ketone, which is most diagnostic for the ketone bodies, which one is most diagnostic?
I'm not sure I understand that question.
Yeah, I think probably what he's saying is of the ketone bodies, you have hydroxybutyrate, acetoacetate, acetone.
Okay.
Which one is most diagnostic?
Okay, so I know that acetoacetate and hydroxybutyrate are important, although acetoacetate can actually be broken down to acetate, And that's what's seen in the lungs when patients, inhale. That's what causes the acetone breath. That is what I am very sure of.
Okay. Well, acetate. I don't know, Jafaru, if you have any other contrary opinion or any other person you can type. Are we to talk about vaginals and other food ulcer grade or only one? Which one is best to use? I think vaginals is the most common one. Discharge information should include food care. I think she mentioned that. Thank you for your explanation. What determines what to switch to, insulin and type or oral antibiotic after resolution of HHS? So what determines what you switch to after resolution of HHS?
Okay. I don't understand what that means.
Okay.
What determines what to be switched
You have
to?
treated HHS, you have treated DKA now. So what are the determining factors that will make you say, okay, this patient
Okay,
needs
so
insulin
when we
or
see
this
that the
patient needs
pH,
OHA?
so when the pH is more than 7.3, okay, the patient is no longer acidotic, and also, of course, and the bicarbonate more than 18, okay, even the iron gap less than 14, we can now consider to transit to the subcutaneous insulin. Yes, that's what determines it, the resolution of symptoms.
No, hello, Dr. Success.
Yes,
Can you hear
sir.
me? Yeah, I
Yes,
think
sir.
what he's asking is what makes you choose between transiting to insulin or transiting to oral antidiabetic agents. But the question is, I don't know. First of all, you have to consider so many things now. Is it type 1? Is it type 2? Is it DKA? Is it HHS? What medication has the patient been on before? So there are so many things that you have to look at. You know that most often times DKA occurs in type 1, but of course you can see it in type 2 too. So, but by the time DKA is setting in, is looking more like the patient is now becoming insulin deficient, and giving insulin, even in addition to maybe oral hypoglycemics, might be the way to go. But you know that from type 1, we rarely use oral antidiabetics. So if it's type 1 that the patient has, definitely it's going to be insulin, right? So
Yes, sir.
I don't know if that has answered the person that is asking the question.
Okay, thank you, sir. So, Dr. Chiweze, please also ensure patient is making adequate urine before giving potassium. If there's hypokalemia, explain how will you correct it before commencing insulin? Then,
Doctor, I think I've answered this question over and over again.
cerebral,
Okay.
yeah, cerebral edema more common if insulin is given before rehydration. So it's just emphasizing that cerebral edema is more common if insulin is given before rehydration. Okay. So I would like you to go over your acute brachial index cutoffs again. Well, I don't know whether we'll have time for that. Thank you for a very,
we don't have time for that.
very beautiful. Thank you for the
If it's on the slide, no problem.
Yes, yes. Please, at what bicarbonate level should you treat?
Yes, on the slide.
Please, at what bicarbonate level should you treat with sodium bicarbonate?
Okay, so some guidelines say less than 12, some said less than 10. However, when there are features of cardiac compromise, you have to replace the bicarbonate.
All right. So, and then last but not the least, beta hydroxybutyrate, most diagnostic.
Please, Dr. Sani, please start sharing your slide, please.
Yes. So, I think that's that for this. For Dr. We thank Dr. Success for the wonderful presentation. So, Dr. Sani, can you put your slides on PowerPoint? Okay. So you can go ahead.
Okay, good morning, facilitators and my fellow participants. I'll be going through this question. I got the short end of the stick and I've got, it's like 20 minutes to 8, but I'll try to finish as quickly as I can. So we have a 15-year-old male is brought to the clinic by his mother. So let's note the age. He has non-pitting swelling of both lower limbs over the past 3 years. So it's a chronic thing. According to his mother, he sometimes has blisters and discharges at the ankle. There is no scrotal swelling. This is also relevant. He has no history of significant environmental exposures. Examination revealed woody edema of the legs with lichenification and hyperkeratosis. Question A says, what is the diagnosis? B, what is the organism responsible for this condition in West Africa? C, how will you confirm the diagnosis in the side lab? D, list 2 acute syndromes associated with this condition. And E, what is the role of doxycycline used in the treatment of this condition? Before I answer, I'd like to ask the people that went for the exam, do they allow one to see all of the questions at the same time, or do they ask them one by one? But looking at the scenario with the picture and the details given and even the questions, we see we're told he's 15-year-old with bilateral edema, but it's asymmetrical. And we're told he has woody edema of the legs with lichenification and hyperkeratosis. So this fits most with, they say, what is the diagnosis? This is lymphatic filariasis. There's a staging for the lymphedema, and it appears this patient from the description has stage 3 lymphedema. When I come to discuss, I will give details on this staging. What is the organism responsible for this condition in West Africa? It's Wuchereria bancrofti. There are other species responsible for the condition in other parts of the world. How you confirm the diagnosis in the side lab? So let's notice in the side lab. The recommended test to confirm quick diagnosis is blood smear. We do blood smear for thin and thick blood films stained with hematoxylin and eosin or GIMSA. And we take this blood sample after 8 p.m. at night because the microfilariae migrate within they have a nocturnal timeline. So it's after 8 p.m. If we take it earlier, we might not find them in the blood. So list 2 acute syndromes associated with this condition. There are a number of them. What I've tried to do is just answer the questions. When we come to discussion, we'll take details. So there are a number of them. I've listed here filarial fever. There's acute adenolymphangitis called ADL. There's tropical. Ma?
Dr. Sani, please, sorry
Yes,
for interrupting you. Please say move all the stuff now. We don't usually encourage wait for the stuff later. Since you're asking the question, move all the important stuff, please.
Okay.
Thank you so much.
Okay, fine. So the other organisms are Brugia malayi. So Wuchereria bancrofti accounts for about 90% of cases worldwide, has a wide geographical distribution, and is the species responsible in West Africa. There's Brugia malayi, seen in parts of Asia, southern India, that accounts for most of the remaining cases, while Brugia timori is mainly limited to the island of Timor in Asia. So this is the diagnosis. I've said nocturnal blood samples taken after 8 p.m. Then acute syndromes include filarial fever, where patients have bouts of fever, joint pains, enlarged lymph nodes and all of that. There's acute adenolymphangitis. There's tropical pulmonary eosinophilia, also called Wenganter's syndrome. So last question says, what is the role of doxycycline used in the treatment of this condition? Now, there is limited evidence to show that doxycycline can kill off adult worms, but that's not very strong. So the main role is that the adult worms have a symbiotic bacteria within them called Wolbachia, and it's important for the reproduction and production of microfilariates. So if doxycycline is given, it can kill this Wolbachia and thus limiting their ability to reproduce. In addition, it might also reduce inflammation and fibrosis within the lymphatics, thus sort of retarding the progression of the disease. So these are the 5 questions that we've answered. I will try to give a brief overview of lymphatic filariasis. I think last week we talked about neglected tropical diseases. So it is one of the neglected tropical diseases. It's found mainly in tropic and subtropical parts of the world. So sub-Saharan Africa, Central, South America, the Caribbean, Southeast Asia, Western Pacific. It is the second leading cause of permanent deformity and disability after leprosy. So this is huge, right? And as at 2019, about 120 million people in 72 countries live with it. It's caused by 3 species of filarial worms, which we will see shortly, and is transmitted by mosquitoes. And there is a WHO program for its elimination, which started in 2000, the year 2000. And there has been a significant decline in its prevalence since the beginning of that program. So it affects all ages, but usually children tend to be asymptomatic till they get to their teens. So like we saw in this patient, in our index patient, and up to 1/3 of children in endemic areas may be asymptomatically infected with Wuchereria bancrofti. So even if they're asymptomatic, they are still reservoirs and contribute to transmission. Young adults are usually the patients with the overt disease and elephantiasis, which is kind of the end stage. It affects males more. There's a 10-to-1 ratio. So one of the few diseases that has a 10-to-1 ratio, with males being more prevalent. So these are the 3 worms that cause lymphatic filariasis. We have Wuchereria bancrofti, which, like I've said, accounts for up to 90% of cases, and it's transmitted by most of the mosquito species. I'll show them in the next slide. Brugia malayi is responsible mainly in China, Southeast Asia, Southern India, and is transmitted mainly by Mansonia, while Brugia timori is caused just a small proportion of infestations in Timor Island. So these are the 5 mosquito species that are the vectors for this disease. Aedes, Anopheles, Culex, Mansonia, Ochlorotatus. Brugia malayi can be transmitted by, I think, at least the first 4. This is the life cycle. So starting from when we have microfilaria in the blood, within the human, they mature into adult worms. There are males and females. The females are much longer. They produce millions of microfilaria in their lifetime, which circulate within the lymph, and in the night they come out into the blood. When a mosquito bites the person, they take up this microfilaria L1 stage, which mature within the mosquito and migrate to its proboscis, so that when it bites somebody else, it's deposited into a new person, and that starts infection. So main pathophysiology is that the larvae are deposited either into the bloodstream or the skin, and they migrate through the dermis or subcutaneous tissue into the lymphatics. The adult worms nest within the lymphatic and cause obstruction and chronic inflammation, and they can live pretty long, so 6 to 8 years, even longer. I think the females can live up to 9 years, and they produce many microfilaria, which perpetuates infection in endemic areas. We could also have immune-related phenomena like glomerulonephritis. So humans are the primary reservoir. This is important, and this is why it can be eliminated, because we don't have animal reservoirs or environmental. Mosquitoes are the vector. When they deposit the larvae, they take up residence in the lymph nodes and lymphatics and grow into adult worms. They have a predilection for femoral lymph nodes. That's why many of the presentations are in the lower limbs. They undergo sexual reproduction. Females give off eggs, and the adult worm proliferates, occludes, causes inflammation, and there's risk of secondary infections, especially streptococcal and fungal infections. And also inflammation occurs due to presence of this Wolbachia. So this cyclical thing leads to chronic inflammation, skin changes, damage of the lymphatics, and all of that. So the clinical features, we've said that majority of children are asymptomatic until their 2nd to 3rd decades, like our index patients. Early on, children may develop a hydrocele, but established disease usually seen in 30s to 40s. Now we have acute manifestations, which may be precipitated by these secondary bacterial infections. And the acute manifestations or syndromes may complicate a background chronic disease. So people, like the patients, keep having attacks of these acute manifestations. We have filarial fever, which present with non-specific symptoms, headache, fever, malaise, joint pains, with lymphadenitis in the inguinal or axillary region or even other sites, and lymphangitis. So we have sudden swelling of the scrotum, vulva, and other sites. So there's acute dermatolymphangioadenitis, which has repeated bouts of lymphangitis that contributes to the long-term lymphedema. We have tropical pulmonary eosinophilia, which would cause nocturnal cough, shortness of breath. Eosinophilia in the blood is an immune response to the filarial infection. We could have acute epididymoitis and funiculitis. Funiculitis is inflammation of the spermatic cord. And we could have filarial abscesses. So localized areas of dead worms, inflammatory cells, and all of that. And when they rupture, there's release of dead adult worms. We could have chronic granulomatous reactions to this, in which case it would be a chronic manifestation, which can lead to nodules and lumps in the subcutaneous tissue and skin. Now, the most common chronic manifestation is, of course, lymphedema. Usually affects the lower limbs and genitalia. Recall we've said femoral and inguinal lymph nodes are the most affected sites, but they can also affect the upper limb, the breast, and can give peau d'orange when it affects the breast, and it could resemble breast cancer. So it's graded based on the extent of the condition. So stage 1, you have extremity pitting edema that is reversible. Our patient didn't have this. Grade 2, we have extremity pitting edema or non-pitting that is non-reversible. By grade 3, we have started getting skin changes. So we're told our patient has hyperkeratosis and lichenification. So that's stage 3. And stage 4, we have non-reversible non-pitting, with thickened nodular appearance of skin. This is the elephantiasis stage. So people could also have long standing hydrocele, and they can grow really, really large. We could have giant scrotum. Other manifestations include chyluria, lymphadenopathies, testicular inguinal pain. So just to show some of this, so we could have like really gigantic scrotum, like this patient has different stages of the lymphedema and the lower. Most of the patients here look as if they have unilateral disease, but patients could have bilateral disease and asymptomatic. Then, of course, breast edema, you can see peau d'orange is not too clear, but you could see it here at the surface of the breast. Now, complications could include tropical pulmonary eosinophilia, which is one of the acute manifestations. We would have filarial arthritis if there's deposition near joints, filaria-associated immune complex glomerulonephritis. So there's chronic inflammation going on, and we could have immune complex mediated diseases. We could have filarial breast abscess. Then in an effort to treat, some of the drugs that are given, like diethylcarbamazine, can flare up lymphatic or onchocerciasis, which can coexist in these patients. They could have depression, social isolation, and stigmatization with loss of gainful employment and poverty from this. I mean, it can be pretty debilitating. So how do you diagnose? You've already mentioned thin and thick blood films using H&E or GIMSA with a nocturnal blood sample. There are other methods, but this is kind of the gold standard recommended by CDC and WHO. But we could do scrotal ultrasound in patients that are fairly asymptomatic, only just have mild scrotal swelling. That will reveal movement of adult worms in otherwise asymptomatic males. So the so-called filarial dance sign, which is a pattern of worm movement that is seen in the lymphatic vessels around the groin. We could do PCR, polymerase chain reaction. There's room for circulating filarial antigen tests, lymphoscintigraphy, and high-end immunochromatographic tests like fluorescence in situ hybridization. How do we treat? So the spectrum of treatment offers probably depend to some extent on the stage or chronicity of the disease. When patients already have chronic lymphedema and elephantiasis with deformities, it is difficult to treat. Of course, it's multidisciplinary. We need, in addition to ID specialist or community health specialists, we need, there are people called lymphedema therapists, actually, but also social workers and all of that, occupational therapists. So where there are general non-pharmacological methods that help to prevent progression to that end-stage elephantiasis, patient and community education, hygiene and skincare, like just regular washing with soap and water, wound care. So when they have wounds, it should be treated quickly, taken care of. And we could use topical antibiotics, antifungals when there is skin infection to prevent flares of, we've said that those acute syndromes are precipitated by infections, limb elevation to help drainage, compressive bandages, pneumatic compression. There are exercises that help with lymphatic drainage. They should wear shoes because sometimes they go around without shoes, and that contributes to trauma, infection, and there's that vicious cycle. Of course, psychological support and rehabilitation, and then socioeconomic support and occupational therapy. So when we give medications, what they mainly do is kill the microfilaria and reduce their intensity, interrupt transmission. They have very limited effect on adult worms. The choice of drugs depend on co-endemicity with especially loasis and onchocerciasis. Because like we've said, some of the drugs like diethylcarbamazine that is very effective causes flares and reactions and progression of disease in loasis and onchocerciasis, so should be affected. We could use doxycycline as an adjunct, but it's not part of WHO regimens, and there's limited evidence that it is able to kill adult worms, but we can use it for those reasons earlier mentioned. So DEC is effective, but we've mentioned that it causes severe reactions if you have loasis or onchocerciasis. So the medicines are usually administered like annually or twice a year as part of a WHO elimination program through mass drug administration. But if we have an individual, the CDC recommends that we could use 1 or 12-day regimens using diethylcarbamazine, of course, when we've ruled out loasis and onchocerciasis. So what are these WHO regimens that are given as mass drug administration? One of the most effective is a triple therapy, including ivermectin, DEC, and albendazole, given annually if there is no onchocerciasis in that region and where they have met conditions for that program and supply of the drugs from WHO. We could use albendazole alone twice a year if we have loasis co-endemicity, and ivermectin with albendazole in countries with onchocerciasis, then dual therapy with DEC and albendazole in patients. So I mean, there are endemicity information for these co-infections across regions. We could treat surgically for debulking of the skin and creating conduits for lymph drainage like lymphovenous anastomosis. We could treat lymphocutaneous fistulas and all of that, and surgery for hydrocele. This could resolve, but if it will recur, the hydrocele, if a patient like there's still endemicity in the area. So that so the mainstay of treatment is really that mass treatment to control it. So we could eliminate lymphatic filariasis by stopping the spread through preventive chemotherapy with safe medicines combination that are repeated annually through mass drug administration. So this program, the WHO Global Program for Elimination of Lymphatic Filariasis, has been doing that. And there are countries that have achieved actually elimination, about 17 countries or so. Of course, other measures include the mosquito control, differential diagnosis, the other filariasis and so onchocerciasis and all of those can be differentials. Of course, lymphoma, we're talking about enlarged lymph nodes and lymph obstruction, enlarged testes, you have testicular, pelvic or breast neoplasms, then congenital anomalies of lymphatics, and damage to lymph system secondary to surgery or radiation. So prognosis is usually good if identified and treated early. This annual mass drug administration reduces risk of reinfection. So even if a person is treated, if there's high prevalence in the region, they could get reinfected. So those acute syndromes we spoke about, we said they can be very debilitating, and they contribute to loss of income and all of that because patients could be bedridden and severely ill for several days or weeks before they resolve. But patients with long-standing edema and skin changes usually have irreversible deformities, which may limit mobility and productivity. So if anyone wants additional information, the WHO fact sheets are very useful. There's the international, broad one, and then we could find specific ones in the regional websites, like the African region. So thank you for
Can you hear
listening.
me?
I hope this has been useful. Thank you. I'm done.
Yeah, thank you for your wonderful presentation. So please quickly, do we have any contribution or any questions, comments, clarifications? The time is fast spent, but we can give our contribution. Dr. Momodu said black witches fly at night. So bruchia and Wilshire samples at night. Okay, I think that's probably and then intermediate host Colex breathes in dirty water, carries Bancrofty Mansona for bruchia malai. So do you have any other comments or any other?
So Bancrofty is carried by most of the others as well, Aegis, Culex, like you mentioned, even Anopheles. So it's not only Culex. It may be the predominant one in certain.
Yeah, and just trying to emphasize where they breed. The Culex breeds. Any question, any contributions, any comments?
Dr. Atta,
Yes, ma'am.
I don't know. I think since they're not, have you read all the comments in the chat box and all the questions?
Yes, yes.
Okay. So I must thank. I think we'll close the class now. It's very some have to go for morning review and other activities. So let's close the class. I must appreciate the presenter. It was quite lucid. She answered the questions. She kept to time in answering the question. So I know it was the extra details that took her beyond 15 minutes. So that's wonderful. Dr. Success too, wonderful presentation, quite lucid and clear. I don't know if any of our facilitators, Chief Chitu, Chief Cookie Manza, Dr. Remigos, any comments, please?
Dr. Christabel.
Yes, sir.
The presenters just blew me away. I don't even have any comment again. Presentation, I was just listening with joy that, oh no, these people are doing very well. So, and they had
they did well.
I was wondering, is Dr. Rukaya, is she in infectious disease?
I'm a cardiologist, though. Well, I have interest.
That was just, see the way Uncle Success, of course, I know that one, she's not an endocrinologist. See the way she was just chopping acute complications of DM. So it was really a beautiful presentation today. Thanks to everyone, and the participation too was top notch. Especially the first one, a lot of people participated, asked a lot of questions. This time around, Dr. Rukaya just dissed everybody. Nobody has anything to say. So I would say that we should keep it up. I like the way we've started this new batch, this new set. Let's just keep it up. Let's keep on going. And at the end of the day, all of us will be happy. Everybody will be successful. Thank you, class, and well done.
So thank you, sir, for the kind comment. So my question, as I started earlier, do they allow one to see all of these questions at once? Because, I mean, they give clues to what the diagnosis could be. Or do they ask them one by one? They have to ask you what is the diagnosis until you
usually
answer
one by one. It's usually one by one. It's usually one by one.
Okay.
Yeah.
Okay.
And that's why we comment this class that wants to be speaking, because sometimes you don't see questions at all. They read it out for you. So you don't even know what they'll ask next. So you have to be a quick thinker. Once they ask a question, you want to quickly answer it. So as I would say, in class, be talking. If they say make attempt, because that's how every exam is, every situation is. Don't say, I know it, Joe. I won't speak. Let me not embarrass myself. It's best now. Nobody knows it all. None of us knows it all. It's best we get it clear, make all the mistakes, say all the garbage now. So once you enter the exam hall, we are saying the real thing, because all the garbages have been moved away from our brain and our brain cells. Because the exam is quite spontaneous. So if it is inside of you, once you start speaking, your sense, you speak subconsciously, actually. You just say, what is this? Sometimes it's like, is it me that said that in that time? So you speak subconsciously. So if it's something you've kept inside, it will come out. And some of these old examiners can easily get irritated, and that is it. And what I also say is that some of the examiners are old, so some of them have hearing deficiencies. So if you are speaking and somebody is like, you didn't say this, so say, but I just said it now. Just say, I'm sorry, sir. I'm sorry, ma. I repeat it. You say, I didn't see here. You repeat it, but make it louder. Don't say, why should I say it now? I need to hear it. Are you deaf? in your mind, but there's a way you look at it, you might say it in your mind, but there's a way your face will look. You're like, this one is not teachable. Let the person come back. So please, it was a wonderful presentation today. The ladies did